this, or your inpatient hospitalization is going to be extended by X amount of time. We just don't have that yet. So
for everybody logging on, we are just chatting. We have not started anything yet. We were just having some chats.
Hey, Dr. Clark, I'm Roxy. Thank you so much for volunteering your very precious and limited time to help us out. And thanks, Mira, for setting this up.
Roxy is the genius behind representation and rehab.
Ooh, the brains behind the beauty. I like it. I like it.
I don't know about the genius. Honestly, everyone, like, I've just been floored by how amazing our students are, and like a lot of the ideas stem from them. I feel like my role is a tech support sometimes.
Very important also.
Yes, yeah. So gosh, are you still at the office, Dr. Clark? Okay, good.
No.
Good.
Don't mind the sweatpants that I might be wearing. There are shorts on here.
No. I'm definitely in pajamas.
Gotta love Zoom.
Yeah.
So I think it's about to be 7, but let's like maybe wait until like 7:02, 7:03 before we start, just to see if a few more people hop on.
Yeah, of course. And I'll be recording it and putting it up. I know like a lot of people logged on. More things, we'll see.
A lot of people texted me and they were like, I can't make it, but I'll watch the recording. I was like, I forgot about the recording. That makes me nervous.
Oh, no, fine. And I always like, if there are any like awkward pauses or anything, I always edit them out.
It's okay. I already told Dr. Clark. I was like, please interject. Please save me.
We've got hand signals, figured out for all this.
How long have you all been working together for?
Honestly, I just kind of stumbled upon Dr. Clark maybe like a year and a half max.
That's what I couldn't remember if it was last year that, because I think
it actually can't even be a year and a half, maybe just a year, but I feel like I've known her for forever at this point.
Spend any time with me at all and it'll feel like a lifetime. That's what I just do.
I think that's probably just like a marker of a good clinician, a good doctor, is like how quickly you can just form connections with people.
Yeah.
Oh, I read a bit about the cancer rehab program. It sounds awesome. There aren't many of them.
Growing though.
Yeah, that's
more
good.
Time. Yeah. I think this year we've got 11 or 12 fellowships.
Nice. Okay. How many were like before?
So it used to be there were just 4 of us.
Oh wow.
Yeah, and then Michigan joined on a couple 3 or 4 years ago. And then last year it just kind of started to explode. So we had a couple, like 3 new ones last year and another couple 3 new ones this year. And
awesome. That's really good. That's great.
Yeah. Now there's like talk about accreditation and everything. So it's moving quick.
Yeah.
It is. I think that's all going to take a good long while, but yeah.
We'll see when we get there.
All right, well, I will mute myself and pass it on to you all for whenever you want to start. There's really no pressure. I'm just here in the background learning.
Okay. Should we give it one more minute? 7:03. We'll start. Just in case.
Yeah. I'm going to. We keep trying to get people to sign up for our newsletter and give us their emails. So we always hide it behind like a sign up thing where you have to like make an account on our website. I think it's working because a lot of people made accounts.
That's good.
Yeah.
All right, well, I am ready to get started if you are Dr. Clark. Perfect. Okay, well, thank you everyone for joining today. It is our first journal club, so that's super exciting. We're gonna have Dr. Clark here with us, and we're gonna be talking about cancer rehab. So just a little bit about Dr. Clark. So Dr. Clark, she trained at the University of Missouri Columbia. She went to med school there as well as residency. And then she came to KU to do her fellowship in cancer rehab. She's been here since, and she's running the cancer rehab. She's the medical director of the department, and then she's also the program director for the fellowship chair there. Dr. Clark, she dabbles in some research. She also is a big advocate for women's health, so it's super great to have her on this call. Personally, me and Dr. Clark, I have been fortunate to kind of get to know her. She has stepped in as my mentor, and so I am super thankful to have her for our first journal club and to be presenting with her today. And so we can go ahead and get started. I'm going to go ahead and share my screen. But before I do that, I guess if Dr. Clark just wants to talk a little bit about cancer rehab and what it is and why she chose that.
Sure. Thank you. Very nice intro. And I always have to say, I am not a traitor to my Mizzou Tigers by coming over to the Jayhawks. I still wear an MU pin every day on my name badge, and they would not let me cover up the KU on my ID. So I tried. But yes, I got into cancer rehab sort of accidentally. It was a wander around the AAPMR annual assembly one year, and there are booths that you can kind of go in and out of. And there was a KU booth actually at that time, and I was gonna kind of give them some ribbing because me and all of my Mizzou gear. And stopped and talked with the doc that was at the KU booth, and just having a conversation about life and what he did. And come to find out, he was a cancer rehab doc. And I had never heard that. I thought he was pulling my leg, but he wasn't. And he started talking about what he did and the patients that he saw and how he used his rehab skills for this patient set. And for me, who was a very confused PGY3, nervous about the prospect of fellowship and thinking about having to choose one area of physiatry, which I loved all of it. So how did I choose between inpatient, outpatient procedures and clinic and brain injury, spinal cord injury, amputee? I loved doing all of it, and I hated the idea of having to neglect some part of it. And so cancer rehab really filled that role for me in that I am a generalist, but I'm specialty trained for the patient population. And so getting to work with cancer patients is very special in and of itself. But for me, satisfaction-wise in my practice, I get to have the diversity that I really enjoy. So I spend some time inpatient. I spend sometimes doing consults. I do a lot of outpatient MSK. I do procedures. I stick needles everywhere. I still even have a fluoro half day that I do some spine procedures. So I really am kind of a bit of everywhere still. And I think it's one of the very exciting parts about cancer rehab.
Perfect. Thank you so much for sharing.
Yeah.
That is also why I love cancer rehab. But onwards to our presentation. Are you guys able to see my screen? Yes, perfect. Now the big question is, how do I make this presentation? There we go. Okay, so as I said, today is our first journal club. We are going to be talking about cancer rehab, and I'm going to be presenting, and then Dr. Clark is going to be facilitating kind of conversation, just talking about main topics and stuff like that. So the name of the paper that we're going to be talking about today is the Pretreatment Optimization with Pulmonary Rehabilitation in Lung Cancer, Making the Inoperable Patients Operable. So that's the name of the title. So a little bit just about what pre-rehab really is. So it's defined as the process of improving the functional capability of a patient prior to a surgical procedure so the patient can withstand any post-op inactivity and associated decline. So basically it's to help kind of keep your patient or it's kind of to help get them at baseline first. So that way outcomes at the end are better. And so we're not having to deal with complications and just decline as we talked about here. And so this paper that we're talking about was done in the United Kingdom. It was actually done in Wales. It was published in November of 2020, but the data collection occurred in January 2017 to December of 2018. And so the lung cancer that we're really going to be talking about today is non-small cell lung cancer. And that actually makes up about 85% of lung cancer. And so the reason that lung cancer is super important is because it actually is the most common cause of cancer mortality in the US. And so it's prevalent, obviously, and we see a lot of it in our patient population every day. And so the other type of lung cancer there is the small cell lung cancer, and that makes up about 15%. In the table that we have on this chart, or on this page, it kind of shows the different breakdowns. So the first one is small cell carcinoma. You can see different characteristics, associations, and then location. But then the ones after this are where we start talking about the non-small cell lung cancer. It's really adenocarcinoma, squamous cell, and then large cell, and then carcinoid tumor, which we talk about a little bit. This paper won't really address the different types of lung cancer, but I think it's nice to get a little bit of a background for what we're going to be talking about. And so the risk factors for lung cancer are cigarettes, radon, and asbestos. Those are the top three. And the average age that we see lung cancer patients, they're about 60 years old. And so the nice thing with non-small cell lung cancer is it really is amenable to surgery. It's kind of funny because if you look at the locations don't really change much. They could be peripherally or centrally, but non-small cell lung cancer is known to give you better prognostic factors and better outcomes if you actually do surgery, versus small cell, you just really treat with chemo and radiation, and you're still able to get good survival rates with that. And so this paper, we're going to be talking about kind of just what these lung cancer or non-small cell lung cancer, and just about the tumors, and really to define how are they resectable, and then what makes a patient operable versus inoperable. And so a resectable lung cancer, the tumor, we're kind of hoping for something that hasn't metastasized. So all these patients that we're going to be talking about, they don't have any metastases, and we're really looking at high risk patients here. And so the way that this paper defines high risk is looking at their dyspnea score, their performance status, their frailty index, and then their pulmonary function. And so on this page, we kind of show the different tables that they use. And so the first one is the dyspnea scale. It's graded out of 4. It starts at 0. In this paper, we're really looking that high risk is somebody after 3. So if they have a grade of 3 or more, then they are high risk per the dyspnea scale. And then the performance status, it's the same way. It's ranked from 0 to 4. But for that, we actually use the value of 2 as starting at what high risk would be. Anything under is low risk, anything above would be high risk. And then this paper talks about the frailty index. They use the Canadian scale for it. And the nice thing with the frailty index is, since we are talking about more the geriatric population, to have another just variable to help kind of start their assessment and have things to compare. And so in this study, we had 306 participants. They were broken, or they kind of got down to 216. The way that they chose which patients would stay in the study and which wouldn't is just by their inclusion criteria, which I have listed. But it basically had to do with the things that we talked about on the last slide. So dyspnea scale, performance status, their age, their frailty index, their pulmonary function. If they're currently smoking, they were kept in. And then if they were sedentary, despite having adequate pulmonary function, they were also still allowed to stay in the study. And then also clinical decision, just as in if the patient, or if the physician thought the patient was going to be a good candidate for this. And so low risk patients were excluded. And so a lot of what this study does is we basically take the 216 patients and we give them prehab. So we go ahead and we do respiratory muscle training and breathing exercises. That's really to help with their diaphragm and their breathing mechanisms. And then we also do cardiovascular exercises. That's more of like the HIIT training that we think about, kind of getting their heart rate above 120. And then also there was a lot of education, especially for the patients that were smokers, on how that can affect their performance in surgery, as well as kind of how that led to possibly their lung cancer, and then also pharmacology if they needed it. That was not used a lot in this study. There wasn't a lot of addition of medications during the pre-rehab part, but there was education on that. And so that's why I chose to include that there. And so these patients basically went through and they got pre-rehab. And from there, we collected the data. The length of stay, the median length of stay was about 39 days for these patients. And so what happened was these patients would come in for their first time. They would have a 70-minute initial kind of PT session where they would learn all these exercises, especially the respiratory muscle training and breathing exercises. Those were taught to the patients, and they would go home and then perform those exercises 3 times a day, and they would come in twice a week. So they would do every exercise at home 3 times a day, but then also come in twice a week to keep kind of getting their assessments and rating them on these scales that we're using. So the results from this kind of did show that the mean age for this study was about 71.7, so a little bit older than that average that we think about as 60. And that, once again, that the pre-rehab stay was about 39 days with 3 sessions a day. And so now if we start looking at these graphs, the real thing that we're looking at here is kind of these black tables, or the black, I guess, like graphs, part the lines, I don't know, I can't get the word right now, but basically seeing how the dyspnea for the pre-rehab went from 40.4 and to post-rehab being 65.1. So your dyspnea score is now kind of going less. So we started off with having the gray bar be higher. In your post-rehab, you're having the black bar be higher, because that's showing that our dyspnea score has decreased. And so we're showing improvement. And so that was seen for, sorry about that. Oops. That was seen for the dyspnea score. You can also see it for the performance status, how it went from having a higher performance status to then post pre-rehab having a lower performance status, as well as like level of activity. I think this one's actually really interesting because it started with sedentary. Obviously, we're having them all do exercises every day, so they are going to be very active, but it's still interesting to see the 19% that weren't. And then from there, you also have your frailty index. And so the frailty index, I guess I didn't talk much about the frailty index, but the frailty index actually scored out of 9. And so it starts with 1 being just normal, 9 being terminally ill. And so just to kind of put it in perspective, for the frailty index, 3 is just having some moderate need for help with IADLs, 5 being you're moderately dependent on more than just your IADLs. You now start need help with ADLs. And then 7 is kind of where you think of more as being pretty frail. They need help with everyday complex, or everyday just basic functions, no longer complex activities. And so in this study, they kind of used 3 as the one that 3 as the number that they're looking at. And so they were able to show the same thing here, is that your frailty index was able to go down post pre-rehab. Those are all pretty good outcomes for the study. And so post-operatively, they also looked at complications. They did have some complications of atrial fibrillation, major cardiac events, and respiratory complications. It was about 11% of patients had atrial fibrillation, and about 26% had some respiratory complication. Only about 1% had a major cardiac event, and that they had it was an MI, and they said it was more due to like a fluke, just a normal occurrence for that patient. We also measured mortality for the patients. And so they looked at 30 days, 90 days, and 1 year. The mortality ended up being 16% at the 1 year mark. And then the median length of stay in the hospital was 7 days after surgery for the control group. And so the patients here that chose to not go from basically sedentary to active, so that 19%, those were the patients that were left over that then became our control group. And there was about 60 of them out of the 216 who chose to not get surgery after doing pre-rehab. And so that's how we get our control group. And so for them, their actual length of stay, they didn't get surgery, but their length of stay after treatment had to be 9 days. And so it's just showing that their complications were longer and that their length of stay was longer. And so a lot of the discussion with this paper is more so that yes, pre-rehab can improve can cause improvements for major thoracic surgery, but more so that you can help with pre-rehab to make a patient operable. So if a patient is inoperable, we can now get them to baseline to actually make sure that they can get the surgery that they need. And with the surgery, they're able to still have lower complications and lower risk than the patients who choose to not get surgery. And so that was a pretty interesting thing for this paper, and that's why this paper is pretty big. When I was reading about it, it's been cited a decent number of times. And then this paper also kind of goes back and looks at other data that's been collected for lung cancer. And so as we talked about the pulmonary functions, the DLCO, there was a paper done by Ferguson that showed if it's less than 60%, you basically get a 25% mortality and a 40% pulmonary morbidity. So what this paper actually did was they split them up. If your DLCO was greater than 50, or sorry, greater than 80%, you were considered low risk. If it was less than 50%, you were considered high risk, is how this paper kind of had done that. And that was just more so for the discussion portion of basically just now proving Ferguson's theory. And so that's what this paper does. And in their discussion section, they talk more about it. It doesn't necessarily have to do with their actual findings and kind of supporting them. It more so was to help support another paper that was previously published for the same topic. And so I thought that was pretty interesting. Other things for discussion, I mean, this study is a pretty interesting study. It was a very well done study, but it was not a randomized study. And so that itself just kind of can have its own implications. And so that would be a reason to redo this study. It's hard to make this study randomized though, because the control group is based off of if your patient wants surgery or doesn't. And so that it's a subjective choice. And so that's why it was not randomized. They couldn't choose if they wanted to give their patient surgery or not. Yes, I could see that being something that happens in the future. It's just kind of hard to take away a benefit from a patient if you know it could help them. And surgery is one of those things for non-small cell lung cancer. Other things that I thought were interesting for this study, they didn't really go into the home exercise regimen. They talked about how they use incentive spirometer and they use diaphragmatic exercises, but they didn't really list them out, and they didn't have any way to monitor that at home. And so that's another thing that could be expanded upon in future studies is, does each patient need to be doing the same type of exercise? Can they be doing different exercises? Can we kind of mix and match? And so me and Dr. Clark actually talked a little bit about this, but just the mix of using anaerobic versus aerobic exercises and how that might play an implication. So yes, as PM&R physicians or hopeful PM&R physicians, we all know that exercise is important. It's just very heavily known that if you move, if you eat well, all those good things cause good things to your body, but there's just not been a lot of data produced to show that. And so I think the study was a really great start, but I think there's a lot more that the study could add on in exercises and kind of breaking down what types of exercises and if a patient needs like a unique exercise versus are they all the same. And so that would just be another way to add on to this study, in my opinion. Other than that, I talked a little bit about the frailty score earlier, but that was one reason why the study was actually very well done, is because as we talked about in this study, the mean age was 71.1. The average age of lung cancer is 60. It really was just showing that resectable tumors nowadays are showing up in older adults. And so that kind of already has now limited them into being high risk versus low risk. And so that frailty score kind of helps to prove that. And that's really what they did in this study, was they showed that you can decrease their frailty index, but they do start off with higher frailty indexes normally. And so that would just be, I think, one thing that we could expand upon later in the future. And so those were a lot of the things that I talked about in the study or thought that were important. I would love to discuss more with everyone else on the call and see what thoughts we had about it.
Thank you, Mira. Thank you. You know, I talk a lot. Everyone feel free to like mute yourself, turn your video on. Yeah. I did have a question if no one else has one. Is essentially pre-rehab sounds awesome, but how often do we actually get it for patients? And like, is this like is this just kind of like a physical therapy referral that they can get beforehand? Is there like a way, like, is there a number of hours or so that would be considered like enough rehab or enough sessions, you know? Yeah, because I feel like when they're inpatient and then they need a surgery and they're on the rehab service, we've had this discussion where it's like, oh, awesome, we're so glad he's been doing rehab because he's going to have so much better outcomes after the surgery because he's basically been in inpatient rehab. But like that, I've heard like some surgeons refer a patient to PT, but like I don't think it happens often. And so I'm curious like what counts as pre-rehab and sort of how insurance, et cetera, is with it.
We'll let Dr. Clark take this one. But just for this study in particular, they actually had a set at this hospital system. So they actually had a setup where they get referrals to all patients with lung cancer if they can meet these criteria. So that was just how the system was set up, or like this research study was set up at this hospital system. But I don't know in general. And so that is a question for Dr. Clark.
I have no good answers, but it is all good questions because it's the same questions we have, right? And Mira and I were talking about this a little bit before, and I stopped myself and I'll say it this time. Historically, rehab docs haven't been very good researchers. And we're just not, because it's easy to say, well, yeah, if they're fitter, they're going to do better. Like, I mean, it feels very simplistic to us that, yeah, obviously we're going to see improvement with it, but proof is in the pudding. And now a lot of insurance companies are saying, okay, well, show us the studies. What is the benefit? Why should we pay for this? Why is this something that, you know, needs to be done? And we go, well, because it's going to help them, but that's not cutting it anymore. So that's what we were saying before we were looking for the papers, is that in the last 5 years, there's been kind of an explosion of exercise as medicine, right? And that while we all feel like in our heart of hearts and in our brains, we know that physical activity is beneficial for people's health, we haven't ever really proved it with metrics and objective measures. And so those things are just now kind of coming around. And it's funny, a lot of the prehab articles, and this one too, are in the UK and they're in Australia, right? Because here in our healthcare system, for better or for worse, you'd mentioned it, insurance. What does insurance do about it? Well, that's the problem. They don't. And since they dictate so much of our care right now, we don't get as many of those programs. So a lot of the prehabilitation stuff or the programs that we see right now are UK and Australia, because they do a better job of it than we do. So I think it's to be determined. Now, one of the things is rehab docs that we're moving that way here in the States, although we're slow, we're moving that way. ACRM has been really good about it in the last few years, and they've had a couple of roundtable kind of papers that they've put out in their exercises medicine efforts. And they have done some in cancer in particular, but they've done a multitude of kind of disease specific provider and patient information on, you know, how do you increase your activity and how do you change your sedentary lifestyle and how do we move you in that direction? So ACRM is a good resource for that too, or ACSM, I'm sorry, the sports medicine group, American College of Sports Medicine. So I always encourage everyone to look at their groups, because I do think it's a good effort as rehab docs for us to get behind and be able to help with. So that's my preface of there isn't enough research on it yet. But the second part, that I don't know if I'm looking forward to the day when we might have the answer of, okay, you have to do 11 and a half sit-ups and 12 push-ups and walk for 5 minutes and then do 4 minutes backwards. Like, once we get that super standardized program, is that better or worse for us than where we are right now? I'm not sure, because the silver lining that I tell my patients right now is that the benefits we are seeing currently are with any physical activity. So for some of my folks, they love swimming and some love biking and some love walking. And I'm able to tell them that keep doing it. Whatever you're doing, we're seeing the benefits. If you can get at least, right now the recommendation is 150 minutes a week to be able to see the physiologic changes. And my guess is that's going to hold true in the prehab world. It's kind of the standard I used with our hematology kind of prehab patients. So you get to kind of choose your own adventure with that. Now, as the future continues on, probably be able to hopefully delineate a little bit better if someone is sarcopenic, right? When we get better tests, we're able to determine, that really it's debility based on muscle mass, or it's cardiopulmonary, frailty, or it's secondary to the cancer itself, or it's neurologic. Maybe we will have more definite guidelines or paths to be able to direct those patients on. That's the hope. But
that's really interesting. I did not think about that. Really, yeah, I didn't think about that. Also, I didn't know about the ACSM, exercise is medicine thing, so I'll have to check that out. Yeah, all things I did not think about. But I also, sorry, we're about to make dinner, so you can hear the blender. But I also, just for all of the MMS4s out there, one of the things that is critical to kind of matching successfully in PM&Rs or any specialty is understanding what the field is, but understanding kind of where it should go, and kind of the issues that are plaguing our field right now. And I would say, Dr. Clark, I hear you about the research. I was on this, and okay, granted, it's hard to do research as a resident, but I hear you completely. I was why PM&R is so awesome, but why is it that we're getting paid a little less in some cases? Insurance isn't covering more stuff. And I was yeah, because we don't really, I don't know why, but it's we don't do a lot of research. As some of the research comes from other internal medicine even. Yeah. So it is very important, I think, for our patients, and I think important for all applicants to understand.
It is, because we're all going to have to be better about it. And we put our money where our mouth is, right? We know that there is going to be benefits that's shown. It's just figuring out how to show it.
Yeah, definitely. Yeah, choosing the right outcomes and all of that. Yeah, no, agree. I think that's helpful to hear. Yeah, I'll really have to check out the ACSM. Thank you.
No, it's definitely a good one. They did a good roundtable, and they brought in, some of the PMR docs sat on it. At least for the cancer one, there were some of the folks that sat on it a couple of years ago, and it's a good.
That's so great. Thank you.
Mix. I don't know, but I completely agree with you. We've got to be aware of what's happening and the changes in medicine. We are potentially positioned very well as rehab docs. We are able to be flexible, and we are able to kind of zig and zag with medicine as it changes and being able to move it. But while it is not typically in our personality as rehab docs, we should position ourselves in the front of a lot of this, because if medicine really does move towards more whole person care and kind of episodes of care, it's going to become increasingly important that we really optimize their overall health through this process. And it's going to be prehab, it's going to be the post-acute care, obviously everything that goes on in between, but cancer as well as everything else. We need to be there to be able to coordinate that care, and who better than the docs that coordinate care all day long.
Yeah, that's so true. That's so true. Yeah. Agree.
So it's exciting.
Yeah,
we should see it as exciting.
Yeah, that's true. Yeah, I mean, I think it is, but I think it was hard. I it was harder for me to understand it as a med student. It's a lot easier to understand it as a resident. When I see a lot of people, I'm oh, no one knows what physiatry is, but physiatry is so important. And anywho.
Yeah. And it's hard, I think well, it was for me. When I was a resident, I was so focused on like, okay, what's the information I have to know to be able to pass that stupid test at the end of all of this? And like, I've got all these things that I'm trying to learn and shove into my head. And the practice management part of it and the, kind of business of medicine part of it, I was aware of, but it's very important. Not all of us are going to end up in academics. I feel very sheltered from a lot of it, being in academics, but not all of us here on this call or listening to it are going to end up in academics. And it's even more important that we understand that piece, which I tie in with the research part of it, because we have to prove it so that we can justify it, so we can get paid for it.
Yeah, for sure. Yeah, definitely. Yeah.
Patients are important too when we want good outcomes for them, blah, 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 blah.
No. But yeah, I do agree. I agree completely. Yeah. Yeah. And you're right. Maybe it isn't part of our personality so much. Maybe we're more like laid back and be like, but no, I think it's true. Yeah. Well, I had a fun time chatting, but I don't know. Sorry. I feel, of course, chatted a lot.
No, thank you, Roxy, for the questions. We appreciate them. But it is 7:34, so I just wanted to say thank you, everyone, for coming. Our hope for kind of what this journal club will be in the future is kind of just to allow medical students to build a connection with an attending. We want them to be more one-on-one, or like two-on-one, so like two medical students, one attending. So that way you really can kind of create a connection with your attending, go through your PowerPoint, send it to them early, get feedback, just kind of build a relationship. I am lucky to have this relationship with Dr. Clark, and I just want every medical student to eventually kind of find their person in the field and kind of find a mentor. And I think this can be one outlet to do that. And at least that's our hope for it. I also kind of love the idea that we started off with oncology rehab. It's not one that people talk about all the time. I mean, obviously I have a passion for it, but it's nice just to talk about the more niche things in PM&R and just the room for growth that we have. And as we've said 1,000 times now, research is super important. And so we hope to make this journal club super successful and allow kids to present whatever topics that they're passionate about. May it be spinal cord or may it be something very niche.
Yeah. Thank you. Thanks so much, Mira. And I honestly just loved hearing about the field as well. I'm curious, maybe we can just add that into other, because it's like, we have an attending physiatrist here who's like amazing and can definitely, I think it's helpful to get a better idea of the field, especially as you're going through interviews. It'll definitely help you out. Okay. Well, thank you, Mira and everyone.
Yeah. Thank you so much, Dr. Clark. We couldn't appreciate it anymore.
My pleasure.
Yeah.
All right. Thank you, everyone, for attending.
I just wanted to add one thing.
Oh, yeah.
I just want to add one thing, Mira. Well, thanks for the presentation. For all the other med students, I was gonna, on the Representation Rehab Twitter page, we're gonna send out a link for you guys to sign up for our next journal clubs. So please be on the lookout for that. And hopefully see you guys next journal club.
Perfect. Thank you, everyone.
Bye.
Thanks so much.
Thank you.